I'm Dr. Ben Weitz. I hope that you'll consider coming to some of our future events. In July 26th, Dr. Karima Harani will be here discussing low-dose immunotherapy. August 23rd, Warren Miller will be discussing EMFs and how to create a healthy home. September 27th, Dr. Jessica Tran will lead a discussion on mold. And I hope that all of you participate in this discussion. Sharon Eller from Metagenics will be coming around with a microphone, so if you want to speak, let her bring you the microphone so everybody can hear. We'll repeat the question as well. Also, please check out my Rational Wellness podcast on iTunes and YouTube. Many thanks to Metagenics for sponsoring the event and providing this great food. I'd like to mention a Metagenics product. They have a new probiotic, Ultraflora Integrity, that's been proven to help with leaky gut. And everybody has a handout about it. And there's actually some clinical research showing it being beneficial in cases of small intestinal bacterial overgrowth, which is one of the conditions we're going to be talking about today. It's Lactobacillus salivarius UCC 118. So Metagenics has some of the best probiotics on the market. One of the things you'll always see is with their probiotics, you'll get the exact specific strain that was used in the studies. A lot of times you'll see Lactobacillus acidophilus, and if it's not the exact strain, it's not necessarily going to have the same efficacy. So our special guest speaker tonight, we really pulled off a coup to get such a prominent functional medicine speaker to attend our meeting and share some of his clinical wisdom with us. Dr. Michael Ruscio is a doctor of chiropractic, a functional medicine practitioner, a clinical researcher, a best-selling author of his new book, The Healthy Gut, Healthy You, which is an excellent book. I'm reading it right now. Great job. His research has been published in peer-reviewed medical journals. He speaks at integrative medical conferences around the world. Dr. Ruscio has a very popular podcast, Dr. Ruscio Radio, and he offers an excellent training program for functional medicine clinicians, the Future of Functional Medicine Review clinical newsletter, which I subscribe to. And that newsletter is very helpful. And that is going to form the basis of our Q&A discussion today, talking about problems dealing with difficult cases for patients with gut and thyroid issues. So Michael, thank you so much for joining us today.
Yeah, thank you for having me.
Excellent.
All right, so I have a presentation for us today, and what I'm hoping we can do is use the first maybe third of this as a springboard into what will be more of a clinical kind of Q&A. But there are a few things that I think are important to lead with to get us all on the same page, and that is regarding the state of functional medicine. I think there's been this well-intentioned hypothesis that more testing will lead to better results. But there's more likely an inverted U with testing's ability to enhance results. Some testing to guide decision making enhances results, but you very quickly tip over into the other side of the inverted U, where if you are using too much testing, first of all, many tests in functional medicine are not validated and therefore they're meaningless measures. And then secondly, if you're trying to treat too many variables at once, you stop listening to the patient. And as I'll show you with this first case study tonight, it was exclusively able to be remedied by listening to the patient and not by lab work. So it's very important that you don't miss cues from the patient and then go chasing more esoteric lab work. Along with this is a problem that is compounded by the fact that information is a form of marketing. Now that's not a bad thing per se, but if you don't understand that and if we don't have a good ability to look at the information and discern, is this high quality and clinically impactful data, or is this someone who's twisting a mechanistic observation to support their view, then you can very easily get misled into treating mechanisms rather than treating patients and rather than treating according to the clinical literature. And what's really needed is a return to practical, cost-effective care, which is progressive, yes, but also conservative and effective. And this is where the evidence-based pyramid really guides us. Now, I could find a cell study or an animal study to support almost anything that I wanted to sell you as a clinician, right? Any position, any idea. It'd be much more difficult to find a clinical trial, or even better yet still, a summary of the available clinical trials, aka a systematic review or a meta-analysis that I was able to contort into showing what I wanted to show. So as disciplined clinicians, we should be looking to the body of science when available to guide our decision making. Now, sometimes there's not robust data present and we have to do the best with what we have and draw inferences from lower quality data. But oftentimes the data is there and people aren't looking at both sides of the data, and they're rather just picking and choosing what works for them. And when that happens, you end up not making the most well-informed decisions for your patients. Therefore, your clinical practice is less efficacious. So it's a key point. So the first case here that kind of pulls some of that together is histamine overload that initially presented as what looked like a SIBO relapse. And this is going to be a hard case study to do because there's a lot of reading, and I guess I can't go over to the podium. Is it a big deal if I go to the podium?
You'll be out of the camera.
All right, do people care? All right, well, I'm going to have to do it because it's more important you look at I read you the slide. So for a little bit of this, I'll be out of shot. I apologize to everyone at home. But these slides are kind of wordy. So Mary was a 46-year-old female with a previous diagnosis of GERD, SIBO, tachycardia, and esophageal stricture. Now, an esophageal stricture is essentially inflammation in the esophagus, essentially forming kind of like a scar. And her chief complaints were indigestion, heartburn, bloating, nausea, alternating loose stools and diarrhea, brain fog, feeling emotional.
And that's something that often is caused by gastric reflux?
What's that?
The stricture?
The stricture, I'm sorry, yeah. So as you have damage to that region of the esophagus, just like if you had damage to the skin, you'd have a scar there. You can have a scar in the esophageal lining. Yes, exactly. Thank you. And she also had cycle abnormalities. So her history and exam visit, here's my initial impression. Mary presents as a generally healthy 46-year-old female who had a good diet and lifestyle. She has experienced a slow progression of her chief complaints. Her reflux and heartburn date back to 18 years of age. Her symptoms are manageable with a low FODMAP plus fast-tracked combination diet and supplements, namely glutamine and enzymes. However, she is still symptomatic. Her bowel regularity and consistency became worse after rifaximin for SIBO, and subsequently after herbal antibiotics, she may have gotten worse even further yet still. She reacts negatively to HCl, and she noted, and this is a key thing to keep your feelers out for, she feels better the worse she eats. Now this oftentimes indicates histamine intolerance or sulfur intolerance, so file that away. It's very important because healthy foods are often histamine rich or high sulfur. So that's a key thing to file away. Now it doesn't mean you jump right to those things, but if you go through your fundamental therapies and they're still floundering, then consider low histamine or consider a low sulfur diet trial. Each one of these only requires a 1-week trial each to get a sense if they're responding clinically. You need no testing to do this. You don't need to test their diamine oxidase in the blood to have them go on a low histamine diet. You can just have them run the experiment. By the time you had a blood test done and got the results back, you could have already figured out if they were histamine intolerant via a dietary trial.
Given the fact that SIBO, after treated, often recurs, how many, do you wait until the second or the third recurrence before you start considering histamine or?
Good question. It depends. If someone responds really well to SIBO antimicrobial therapy and then they regress afterwards, then we may just treat again.
Right. Wouldn't the first thought be, hey, maybe I missed something. Maybe I didn't give them a motility agent. Maybe I didn't give them something to break up the biofilms. Maybe. So
there's a couple different things that can occur here. And typically what I do now in the clinic is after we've finished a round of antimicrobial treatment, I don't follow up right away. I usually follow up 3 to 4 weeks later because I want to see where they end up after a few weeks off the antimicrobials. That would be plus or minus Prokinetic.
How many weeks of antimicrobials do you typically use for a typical case of SIBO?
4 to 8. Now, you could be plus or minus with a natural Prokinetic. Dubious as to whether they do as much as we think that they do. And we're going to be starting that study. Thankfully, it took like 2 years to be able to get placebos to perform a placebo-controlled trial in a natural medicine in the prevention of SIBO recurrence. We're starting that in January. I'm curious to see what happens. It'll be double-blinded. But part of this is just an experiential call, seeing how they were eating before. Some patients may already be somewhat low histamine, and so if they come in already low histamine, you don't need to go there. Other people may not be low histamine, so that would increase the probability that you could go low histamine. And if people responded fantastically to the antimicrobials and then regressed immediately afterward, they may just need a little bit more of an antimicrobial stimulus before they can maintain that in the long term. Because dysbiosis and histamine are interwoven, right? There's multiple ways you can drive down histamine. A low FODMAP diet has been shown in one study to cause an 8-fold reduction of histamine. So you can get there through low FODMAP, you can get there through probiotics, but not in everyone. The relationship between histamine and probiotics is ambiguous. And I do not think it's predicated upon if the probiotic is or is not a histamine-producing probiotic. I think that is a huge mistake, because there's far more to whether the net effect in the biological system of a probiotic will be pro or antihistamine. It has to do with how it affects your immune system, how it affects your dysbiosis, how it affects your motility, how it affects your leaky gut. So to say I'm going to pick these strains because they're low histamine, it's really a fool's errand, because you're only taking into account one factor of multitudes that are occurring in that system from the stimulus of a probiotic. I'm losing my whole train of thought here. No, it's fine. Working through this here, Mary may have dysbiosis secondary to the antibiotics. It's possible that the antibiotics cause some sort of rebound dysbiosis. The negative reaction to HCl, heartburn, bloating, and nausea may also suggest gastritis or even an ulcer. And this does happen. It's important that we aren't bearish with HCl, because this definitely happens in natural medicine. Acid is so important, rah, 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 and you ignore some of the signs of overacidity or gastric lining irritation. So sometimes people need interventions that will lower acid. Does that mean you have to put them on a PPI? No. Do PPI show an 80 to 90% ability to heal ulcers in 4 to 8 weeks? Yes. 4 to 8 weeks, not forever, not as an ongoing management strategy. Think of it like a knee brace. If you were to use that, I'm not even saying you have to use that. So the stricture may also be a byproduct of the reflux and heartburn, as you denoted earlier. And the emotional instability and inability to handle stress may indicate female hormone or fatty acid imbalance. So we could have dysbiosis, we could have a problem with stomach acidity and reflux, and we could have a problem with female hormone imbalances and some typical nutrient deficiencies. But how do we start sorting this out, right? So we have her perform a at-home SIBO breath test, 2 at-home stool tests, and 1 blood panel. And if this were me today, I'd probably do about half of that testing. And the recommendations: continue with your previous low FODMAP/fast track combination diet. Start a modified fast. You can use bone broth or master's cleanse, or she could use an elemental diet formula, and do a 2 to 4 day liquid fast experiment. And then we're going to have her start on curcumin, vitamin DK, magnesium, and omega-369 blend. Some female hormone support, essentially 2 formulas that contain some female hormone adaptogens. And we're going to put her on a natural Prokinetic and 3 probiotics, in addition to a natural acid-lowering compound. Hey, this is Dr. Ruscio. I hope you're finding this lecture and following Q&A helpful. And if you are, I'd like to tell you about the Future of Functional Medicine Review, our clinical newsletter. It's something I've put quite a bit of effort into to try to equip you with some of the most relevant information in sharpening your clinical skills. And we decided for Ben's group to run a special wherein you can access every edition of the Future of Functional Medicine Review, your first month of access, that is, for only $2.99. And what that gives you is access to this month's issue plus almost 2 years of backlogged issues. And within each issue, I summarize some of the most salient, relevant research and summarize it in such a way where you can take away the relevant clinical pearls very quickly and easily. So this keeps you on the edge of what the clinical science is saying, and in conjunction with that, there's also a case study which helps apply the science and helps to answer the questions of what tests do we run, when do we run them, how do we treat someone, how do we troubleshoot, and it kind of integrates all the science together into a clinical model. And as an example, in this month's issue, the month of, this will be for July actually, I propose a very thorough outline for a hierarchy of utilization of various types of thyroid hormone preparations. And if you've been reading the review, you've seen that I've chronicled over a number of months an evolution in the research that gives us hints in terms of when do we use T4 only, when may we want to use T4 plus T3, when might we want to just shoot for a higher dose of T4, and is there a better, and yes there is, accurate measure of free T4 that may pick out cases of hypothyroidism that were otherwise unidentified. And then finally, when might we want to use a liquid or gel capsule form of thyroid hormone? And so I codify all this into a hierarchy based upon following the research for the past several months. So that's just one example of what I'm trying to deliver to you in the Future of Functional Medicine Review clinical newsletter. So I hope you will sign up for your first month of access. This will give you a chance at a very cheap price of $2.99 to be able to really peruse it, see if it's something that you find valuable. I'm very, very inclined to think that you will. And if so, I hope you continue to be a subscriber. This is a real effort on my part to try to improve the quality of the care in the field, which is such a fantastic field. But I certainly think that we can enhance what we're doing and do it better, and this is my contribution to try to move the field and move your skills and move your practice in a positive direction. So hopefully you'll take a moment and sign up. So when we follow up, we find that the SIBO breath test is negative. Essentially all of her testing is normal. Fasting, Mary did not respond well to. That can further tell you that they may have gastritis or ulcers present. When there's not food in the stomach to buffer the acid, sometimes that becomes worse. So I tell my patients that if you have a negative reaction, that's not a failure. We can learn from those things. Maybe we lose the battle, but we'll win the war if we use this information constructively.
By the way, what was your fasting intervention?
The fasting was the modified fast with bone broth or with the master's cleanse or the elemental, elemental diet. So it's a liquid fast, not a true water fast.
And you do that for how long?
2 to 4 days. Okay, so improved. Her heartburn was improved, her PMS and brain fog improved, her bloating and nausea improved, and her stools improved. But worse, the natural acid-lowering compound caused fatigue. This one does contain melatonin. For some people that's problematic. And she also, at her own discretion, attempted the reintroduction of gluten-free flours and starches, and this caused a regression also. Overall, she was 75% improved subjectively, and she commented she wasn't sure if the probiotics were helping her or not. So my impression here, the negative response to fasting reinforces reflux or ulcerations or gastritis. This should make Mary a good candidate for a natural acid-lowering intervention, but unfortunately she was unable to tolerate this. Her response to the natural Prokinetic was not surprising, because if people have too much acid, a natural Prokinetic will help keep things moving downward in the appropriate fashion. So that is befitting. And let's see, her PMS and brain fog were improving. That suggests fatty acids and hormone support was needed. And there's no need to test the female hormones when using adaptogenic herbs, because no matter if they're high or low, they're going to bring you more to a corrective center point. So there's one test of a few $100s you can save your patients right there. And so Mary now is moving in the right direction. So our recommendations now: discontinue the natural acid-lowering compound because it was causing a reaction. Avoid starches and gluten-free flours as best you can. I don't take a hard line on this because that causes, pseudo-orthorexia and fear in patients, which is not helpful. And discontinue any fasting. Continue with the previous program, and we will maintain this program for now and follow up in 2 months. So essentially all I did was take out the things that were bothering her and keep the things that seem to be helping her, right? So sometimes all you have to do is trim some of the fat out of your intervention and give the body time and see what happens. And so we follow up 2 months later, and here's her labs, by the way, clearly SIBO negative. You do see some E. coli, but don't let that throw you off. E. coli is a normal resident of the gut. So her lab works unremarked. Okay, so about 2 months later, Mary had generally maintained her previous improvements with the following exceptions. She was having a runny nose, even though not sick, abdominal pain, nausea, anxiety, and palpitations. Mary also reported again, she feels better the worse she eats. She noted that when she eats lots of fermented foods and or kombucha, she feels worse. So this is a dead giveaway for histamine intolerance, but you have to be listening to the patient in order to pick this out. And this is one of the reasons why I guard against too much lab work, is because if you're looking through all these labs and you only have so much time with your patient, you're going to be so inundated by that, you're going to increase the probability of missing these clues from talking to the patient and listening to how they've responded.
Isn't it possible that this patient had SIBO that didn't come up on a breath test, and that taking the prebiotics was fueling the bacteria in her small intestine? Maybe she had hydrogen sulfide SIBO?
Well, it is possible, but when we get through a little more of this case, I think you'll see that it was probably not that there was dysbiosis, because the probiotics were actually making her worse. So, and that's what you see here with this next recommendation and then follow-up. That's a great question. So the fact that Mary was experiencing a flare of runny nose, even though not sick, abdominal pain, nausea, anxiety, and palpitations are highly suggestive of histamine overload. She also reported that too much fermented food intake flares her. This further suggests histamine overload. So we follow a low histamine diet. So this is where we're going to start now, the low histamine diet, and discontinue all probiotics, which are a source of histamine. But remember, they're not universally helpful or problematic for people with histamine intolerance. You have to take it on a case-by-case basis. Okay, so recommendation, follow a low histamine diet, discontinue all probiotics while maintaining your previous program, follow up in 4 to 8 weeks. So 4 to 8 weeks later, the stomach pain, reflux, runny nose, stools, bloating, and brain fog are all improved. Mary felt the low histamine diet was very helpful. She also noticed that the lacto-bifido probiotic and the soil-based probiotic caused negative reactions, but the S. boulardii was okay, right? So it's very individual. So that's why we want to, and that's why it's important to understand the 3-category system of probiotics, which I talk about in the book, but essentially Lactobacillus bifidobacterium category 1, Saccharomyces boulardii category 2, soil-based probiotics category 3. Those are typically bacillus species. So she did well on Saccharomyces boulardii. So impression, reducing Mary's histamine load was helpful and was the last piece needed to be addressed to reach full symptomatic reduction. Did we lose that? Sorry. Okay. The fact that she had been off the natural acid-lowering agent suggests she did not need, or they were not needed for heartburn, reflux, and stomach pain. Interestingly, histamine is involved in gastric acid secretion, so by improving and reducing her histamine load, we were likely able to get to the root cause of any hyperacidity that might have been present. Remember that one class of acid-lowering medications are histamine antagonists, H2 antagonists. Okay. It's important to encourage Mary to adhere to whatever follow-up her conventional GI is recommending to make sure someone is keeping tabs on any potential changes in her esophageal histology, but hopefully our work will prevent any regressions there. So we essentially have her continue with that same program, but one change, work to expand your dietary boundaries with your low FODMAP, fast track restrictions, and follow up in 2 months. That is key. We want to encourage people after they've been improved and stable for a few weeks to expand their diets. They have a tendency to go toward more restrictive diets, many of them. You have to read the patient, right? If it's someone who comes in and they're like, whatever, I don't care. You don't have to really worry about them going on the internet and reading about low FODMAP, low lectin, right? But if it's someone who comes in and they're definitely doing a lot of reading and research, you have to make sure to pull them out of the invariable black hole of dietary restrictions they will sink into. So that's why I make this recommendation, and that does make a big difference. So her final visit, Mary has maintained all previous improvements and even reports she feels slightly better. She has been able to slightly expand her dietary boundaries. So overall impression, Mary has done great. No more improvement is needed. We can maintain this program for a few months and then start curtailing off the supplements in her supplement plan. Recommended follow-up in 2 to 3 months. And here's kind of my final thoughts, but we can kind of gloss over that because I think we hit on most of those. So in that case, 1 probiotic helped. So that may have indicated there was a degree of dysbiosis that we weren't able to find on the lab work, or it may just have meant that for her gut and for her immune system, Saccharomyces boulardii had a positive impact where the other 2 probiotics did not. And the main thing in her case was just sniffing out that histamine intolerance, and she did very, very well. So questions on this?
Yeah, so one question is, I know that it's helpful to sort of put these limited number of categories on probiotics, but as the research comes in, we find out that a particular strain has particular efficacy, and just sort of lumping all Lactobacillus acidophilus strains is really missing a lot of that. The Lactobacillus plantarum strain 299B has been shown to be helpful in reducing inflammation in Crohn's disease, and so, you know, we go on and on about these particular strains. So
I would actually politely disagree with that, because if you keep reading, you start finding that the 1 probiotic that helped constipation in the pivotal study 4 years ago, that same improvement in constipation has now been shown with 2 or 3 other forms of probiotics. And I went through that same thing initially, where I was starting to go to websites like probioticadvisor.com and look up what probiotic had the best efficacy. But then I kept looking at more and more studies coming out showing reduced inflammation, reduced leaky gut, antibacterial activity, anti-candidal activity, the ability to help with constipation, the ability to help with brain fog. And you fairly quickly realize that as more research is being done, it looks like, and again, I'm totally open to making it more complicated and more precise if we need to, absolutely. But as I kept on reading, I kept seeing that we would see different formulas producing the same benefit. And so I don't think we have a definitive data set, but I'm a strong believer that if you frame things one of 2 ways, you'll end up at very disparate positions. If you're trying to look for the complexity, you will make your practice so much more complex. If you're trying to look for the simple fundamentals, you will make your practice so much more simple. And that's important because the more complicated your practice is, the harder it is to read these things from your patients. So, you know, again, I don't think we have the definitive answer there, but there have been enough instances where I've seen different formulas show the same thing that I now see it as, it's not like a drug. This drug is going to lower your cholesterol, or this drug is going to increase your thyroid hormone. It's more so a stimulus to an entire ecosystem, and we're not sure how that stimulus relative to that ecosystem and that immune system will manifest symptomatically. And maybe at one point we'll get there, but even if we look at the microbiota and try to use microbiota mapping in a predictive model to show what probiotics one would respond to, we're still missing the immune system component of this. So I think it's going to be a while before we get to a point where we can say, here's our test, this tells me that you'll do better on this probiotic compared to another probiotic. That's such a good question. It's something I struggled with also for a little while, but you know, again, as you look deeper, it looks like it doesn't, thankfully, have to be that complicated.
And I've heard you talk about the fact that probiotics, in your opinion, have an antimicrobial effect.
And
Can
so
you
this
talk
is
about that? Because I don't think that's well understood.
Yeah.
You know, we usually think of probiotics as something you add in the 4th phase of the 4R program, right? The reinoculate phase, not in the remove phase. But you like to use probiotics as part of the remove phase, right?
Yeah. So this is where I think there's one of the biggest divides between what the data shows and what some of the experts say. Now, normally we follow an expert opinion because the expert is the most well-versed in the data. But sometimes the experts are ignoring the data, and with probiotics and SIBO, this is definitely occurring. There is one meta-analysis that has shown that probiotics can successfully decontaminate the small bowel of SIBO. Different types of probiotics have been used, because remember, a meta-analysis summarizes the clinical trials, right? So we have different clinical trials with different probiotics, all concluding that probiotics can decontaminate SIBO out of the small intestine. We also have a number of studies showing that probiotics can help with the symptomatic presentation of IBS, which SIBO may underlie. So when we look at the symptomatic data, the SIBO data, I am at a loss for how any well-informed researcher or clinician can say not to use probiotics and SIBO. Does that mean that they will help everyone? No. Does that mean that some people won't react negatively? No. There's a case right here where someone reacted negatively. But it would be a real mistake to discount or not use probiotics, especially early on, because they are antibacterial, antifungal, antiprotozoal. So you can have the same effect as a full-on course of herbal antimicrobials or even antibiotics and antifungal agents when using a course of probiotics. Plus you get reduction in leaky gut and the other health benefits of the immune toning and what have you that you get from probiotics.
But you can understand how it's counterintuitive. The problem is you have too much bacteria, and now you're recommending putting more bacteria.
Right. Well, that's why you have to look at the data, though, right? That's why you should be looking to the data and saying, wow, it appears, and this apparently has been known for quite a while. I remember when I was first talking with Alison Seebecker about this, probably 3 years ago now. I said, do you think that probiotics... The Queen of SIBO, yeah, I love Alison. And I said, do you think probiotics have a substantial antibacterial effect? And she goes, oh yeah, they definitely do. And as I started looking more into this, like, wow, here's an antiprotozoal agent next to a probiotic in treating a protozoa. They show equivalent effectiveness. It's like, whoa, these things are powerful as antimicrobials. So they can be used, and you can save some patients from needing to go to either antibiotics or antimicrobials by using a probiotic. If you have to go there, other meta-analyses, most namely with treatment of H. pylori, show that if you give an H. pylori antibiotic combined with a probiotic, you enhance the ability of the antibiotic to eradicate H. pylori. So they're synergistic. It's not, don't take the probiotic because the antibiotic will kill it. They actually work synergistically, and the probiotic can help counterbalance or protect against any negative skewing of the microbiota from the antibiotic. I'm passionate about this, as you can tell.
Are you taking them concurrently, or are you taking one morning, one night?
If you
So
can repeat
are we
your
taking
question.
the
Could you repeat your
probiotics
question?
concurrently? Is that what you're asking?
With the antimicrobial?
So all right. So the question is,
So
do
at the
you
same time.
right? Do you take the probiotics and the antimicrobials at the same time? Theoretically, it may be better to separate them, but I don't know that it really matters. And here's one of the reasons why. There have been a few studies, and I talk about this in the book also, using heat-killed probiotic strains. So they kill the probiotic, and then they administer them, and they still show benefit. So them being alive may not be
Or people
hugely
getting benefit from miso soup, which
Right,
is heated,
right.
etc.
So what I've noticed is, and I'm probably going to take this out of our kind of protocol recommendations, because we do put in our protocol write-up, try to separate them, and I hear maybe 30% of the time, oh, I haven't been that great with the probiotics because I get up and then this and that, and I can't separate them. So in my mind, again, complicated or simple, where do you want to go? And you will see patients come in from other practitioners, here's my dosing thing for the day. There are 18 steps. It's like, whoa, I get you're trying to help, but this is only going to be able to help the smallest echelon of highly motivated patients, and you are going to be making your practice less accessible to the masses by doing that.
You'll be talking about the relationship between this and the thyroid?
We will, yeah. Do you guys want to go there now? Okay, all right. So the question was, will we be talking about the relationship between gut, SIBO, and thyroid?
Can I ask one more question about the case before you?
Sure.
I was curious how you knew there was a stricture. Did she come in with a diagnosis?
Yeah, she came in with a diagnosis already from her GI.
How did they test it?
I'm assuming that's EGD, endoscopy.
So I can see you have protocol.
Microphone.
So have you dealt with the die-off effect?
Have I dealt with the die-off?
Yeah, because this patient clearly, taking all the antibiotics and probiotics, they are die-off effect. The question would be, do you know whether the liver or kidney, etc., can handle it?
I think there's a majority of patients who actually don't have die-off, but are negatively reacting to the antimicrobial intervention. And I think the way you figure that out is the time. A die-off typically rolls on and rolls off, right? It may peak day 3, 4, 5, 6, and then it fades away. In most cases, may there be a rare exception to that? Yes, but generally a die-off has a kind of inverted U, the spread inverted U kind of onset and wean off. But what happens is sometimes practitioners are so fixated on die-off, a patient is still having negative reactions like joint pain and brain fog 4 weeks in. And the narrative there is, oh, it's a healing reaction, you got to work through it, or we have to support your liver, which I'm totally open to. But what I do in those cases is have them use a different form of that same treatment. And oftentimes what happens is they feel better in like 2 days. So I think that, and I also talk about this in the book, I think that timing is a way that you can suss that out for most cases. And I tell my patients this: if you have a negative reaction that starts shortly after this treatment, if it lasts for longer than a week, then you may be allergic or somewhat allergic or intolerant to the agent that you're using. So that's how I approach this. Now, there are also some cases where they feel a little bit worse while on the antimicrobials because they can be a little bit noxious to the gut. And then when they end the antimicrobials, they start feeling better than they did before. I saw a case of this just last week. He was getting better from our initial recommendations. Then we started the antimicrobials. He regressed by about 20%, but it wasn't so much where we had to stop. Right? And so that's, you need to kind of key in on that. Is it debilitating? Is it really bad? Or is it just a little bit upsetting? So for him, we continued forward. We followed up 3 weeks after he ended the antimicrobials, and he goes, I feel better than I felt in years. So sometimes that does happen, and it's important to remind patients of that. And I explain it as such. Some patients respond right out of the gate. A couple days in, and they're already feeling better. Other patients, it's a slow, steady improvement that they get little bit, week after week after week. And then other patients don't improve until after they've ended the antimicrobials.
Have you noticed that some of the antimicrobials, like the oregano oil and some of the aromatics, maybe are more likely to elicit side effects, and you have to wean them off those, or do a lower dosage, or have them use it with food?
Yeah, so with food, actually, I find to be very helpful, especially if people feel nauseated or refluxy, because these things, if they sit in the stomach, they theoretically could be more problematic if compared to if they had some food in there to buffer the effect. So taking them with food, and I may just move over to this completely. Again, to make things simple, I may say take all your stuff 2 times a day. We've already moved a lot of our protocols in that direction, and it may just be the same thing where, unless it's something that clearly has to be dosed empty stomach or with food, we may just make everything with food for simplicity's sake. Because again, I'm thinking about how can I help the most people. Also, will the difference in effectiveness between those who take them on an empty stomach and with food, are we going to be talking like a 60% jump in efficacy? Probably not, if it's even measurable. And I can't say I've noticed one type of antimicrobial to be more problematic than another, but for patients who are sensitive, we tend to use one ingredient formulas rather than multi-ingredient formulas, because obviously that way you only have one compound you could be reacting to compared to one compound with 6 ingredients in it. So if someone comes in, and this is one of the questions in our paperwork so that we can sniff this out right at the onset with a history of being reactive, then when we get to the antimicrobials, we will recommend single ingredient antimicrobials rather than combination formulas.
And for the low histamine diet, you have a great resource that's available. Can practitioners access the low histamine diet from your website? I've also posted it on our Facebook page.
Yeah, I sent you the link.
Yes.
I don't know the URL off the top of my head, but
right.
If you search my name and low histamine, that will come up. And also, if you read the book, there's a link in there that I don't give out unless you bought the book, sorry. And that gives you a bunch of resources. Low histamine, low sulfur handouts. There's a question forum. So I think for all practitioners, the book is a great resource because it helps codify all this for you into
I also added it to our closed Facebook page, Functional Medicine Discussion Group of Santa Monica. So if you're not a member, to hop on there.
You mentioned that it doesn't seem to matter what probiotic you use. So do you have any product recommendations, or is it really just a probiotic? Just roll the dice, or?
Well,
it's always baffled me, like selection of probiotics.
Sure. So I like to have people experiment with one quality manufacturer formula from each of the 3 categories. You do want to be careful that the probiotic doesn't contain more than 1,000 milligrams of prebiotic, because some have a decent base of prebiotic, and you may see a confounding reaction that you think is coming from the probiotic, but it's actually coming from the prebiotic. So you want to make sure that it's just got your standard. I think most probiotics have about 400, 500, 600 milligrams of prebiotic in them, and be careful that there's not more. And then the other would be if someone's sensitive and has a history of being reactive, I would have them start with 1 probiotic at a time every few days or even longer. And then in terms of brands, there's a lot of good probiotics out there. There really are. I think it's more important to just use a company that you trust and try 1 probiotic from each of the 3 categories. You could use, some probiotics are now pulling together soil-based and Saccharomyces and Lactobacillus acidophilus bifidobacterium blends, and I'm open to that. But again, coming back to simplicity, this gal, if we had used a combination of all 3, she'd always react to that probiotic, right? We'd never be able to suss out where the reaction is coming from. So you don't have to do it the way that I'm recommending, but I think that can help reduce confounding variables to it.
And is spore-based probiotics another category?
Yeah, so that's category 3. Category 3 is soil-based or spore-forming.
Oh, so soil-based and spore
They're
forming
kind
are
of
the
loose
same?
AKAs
Okay.
for one another. Apparently there's a nuance that delineates, and I'm not fully clear on exactly what that is. But you're looking at typically Bacillus subtilis, Bacillus clausii, Bacillus licheniformis, and Bacillus subtilis are the 4 most studied. There's a couple other, but those are the 4 most studied soil-based or spore-forming probiotics.
Okay.
Can I get your opinion on when you use short-chain fatty acids?
So when I use short-chain fatty acids, like butyrate, do you mean? Supplemental butyrate?
Yeah.
I don't really use butyrate. I think you can make the best case for non-responsive, potentially distal Crohn's or ulcerative colitis as a butyrate enema. Potentially taking it orally, I'm open to that. But I also came across what's known as the butyrate paradox, where butyrate, and some of the details on this are fuzzy now, I apologize, but butyrate seems to flare some people. I don't think the utility of short-chain fatty acids are as important as we've been led to believe. There's a niche of thinking that feels that you have to feed bacteria in order to improve one's gut health, and there are flagrant contradictions to that in the clinical trials. And I very much so outline this in my book, because I really wanted to help people be anchored amidst this microbiota craze where everyone's wanting to feed your gut bugs and use fiber and use prebiotics, which can help. But kind of the bottom line with this is, the more symptomatic someone is, especially digestively, the higher the probability that they will flare from fiber, from FODMAPs, or from prebiotics. So with those people, they are one of the last things that I introduce. For people who are fairly healthy and have mild symptomatology, then you could use those earlier on. The dose also matters. 3 to 5 grams per day of prebiotics seems to be the sweet spot where you get benefit but prevent a higher occurrence of adverse events. And for fiber, a predominantly soluble version of fiber tends to be less reactive or less able to drive adverse events. And the IBS subtype also matters. Those with constipation will clearly respond better than those with diarrhea. So don't use fiber to try to slow things down, because that will just flare the diarrhea in most cases. But if someone has constipation, then a predominantly soluble fiber is definitely something to consider. And just 1 or 2 other things there. We do see in some ill populations high levels of short-chain fatty acids. And we also see, there's so much here. We also see that a low FODMAP diet, at least according to 2 studies, and Tarek Mazalwi, who was on the podcast a while ago, who's a researcher, I believe he's based in the Netherlands, his group has found that a low FODMAP diet in IBS patients can increase the serotonin cell density in the intestines to more like that of healthy controls. So there's a lot more happening with some of these bacterial reducing interventions than I think we appreciate. In addition to that, the low FODMAP diet has also shown the ability to lower histamine, as we mentioned earlier, reduce leaky gut, and reduce inflammatory cytokines.
Did you also see the literature about how the short-chain fatty acids are interacting with the dendrites and signaling to the immune system to calm down?
Yes, but here's the problem. That, coming back to the pyramid, Where does that fall in the pyramid? Because this is key. This is so critical. So this is.
What if it's lowering histamine by signaling to the immune system to calm it down?
But what you're citing is a mechanism. You need to tie that to a clinical outcome in humans. And that's where the problem comes from. People are citing, oh, short-chain fatty acids are anti-inflammatory. But what happens when we give people who have inflammation in the gut lots of prebiotics and FODMAPs? The inflammation gets worse. So that's why it's so important to stay grounded here. You're looking at an observation in a cell study, and that tells you, give people lots of FODMAPs. We do that in clinical trials, and they actually get worse. We reduce the FODMAPs in clinical trials, they get better. Now, is that an absolute rule? No, but there's a trend that it seems you're more prone to run into speed bumps and turbulence with that approach of feeding the gut bugs with patients who have digestive symptoms, IBS, IBD, what have you. That's a really key point. So that's something that I think all providers would do very well to better understand, because I fall into that same thing. And I remember being on a panel at PaleoFX like 4 years ago when I was just kind of figuring some of this stuff out, and some of the panelists were driving me nuts because they were so pro prebiotics. And I remember going home and saying to myself, why am I so angry about this? Right? Because they say sometimes the people who irritate you the most are actually a gift because they help you figure things out. And so I said, are they wrong or am I wrong? And why am I mad? And I said, well, because the clinical studies show that when people with IBS and IBD go on high FODMAP diets, not absolute, but the majority of those tend to get worse. But these people are citing studies that are not factoring that in. They're just getting raw probiotics, short-chain fatty acids, gut healing. And I said, so there's where the problem lies. It's the fact that if you cite mechanism and you don't check that against the outcome trials, the clinical trials, you can easily be misled. And so that's crucial. Now, sometimes all we have is mechanism to draw inferences from. But we have many trials, over 10 trials, probably even more, of the low FODMAP diet showing benefit. So it's confusing when you don't know how to weight the quality of your data, but you always want to check what a mechanism suggests against what happens when we test that mechanism with a group of humans and look at the outcome.
Now, what do you think about the 4R program? So after you remove the problems, get rid of the bacterial overgrowth, you use your antimicrobials, etc. What about when you're into the rebuild, repair, reinoculate phase? At that point, does it make sense to use prebiotics and try to rebuild, the colonic flora and make sure you have a diverse microbiota?
So I invert some of the aspects of the 4R where we use probiotics earlier on because probiotics can help remove. So it's not remove with antimicrobials and then use probiotics, because you may be able to not need the antimicrobials if the probiotics do their job effectively. On the tail end of that, and I also outline this in the book, we then have people experiment with some supplementation with prebiotics and fiber because it may help them. But we categorize people. So people who came in, they were generally healthy, just a little bit bloated, a little bit constipated, but generally they're in good health. They may be able to go right into fiber and prebiotics and do great. But people who come in and they've had recalcitrant IBS or mild to severe inflammatory bowel disease and they've been flaring on and off for years and years and their symptomatic presentation is fairly severe, you do not want to start with the prebiotics with them. You want to go through all these other interventions first, get them to a place where they're healthy and stable for a couple months, then perform a cautious and have that conversation where you may benefit from the prebiotics and the fiber, but you may flare. So let's do this with our eyes wide open and cautiously. And for some people, they will help. Clearly, they can help. But I think the thing that's left out of this dialogue is the immune system. Because short-chain fatty acids don't work in isolation. And it seems that in people with IBS and IBD, the microbiota and the immune system don't get along. And so you have to be careful with how much you feed the microbiota, because that may flare some people's immune systems. So they may work. I just use them cautiously and more as one of the final considerations, especially in patients who are, more severely symptomatic.
Now, we had Dr. Rabar speak several months ago, and he was talking about difficult IBS patients, and you run a stool test and it shows a low secretory IgA. So his interpretation is that means the immune system's not functioning properly, it's at a low level, so he uses certain supplements to try to beef up the immune system before he goes into an antimicrobial phase.
Well, you know, I don't think I've read one study that showed that secretory IgA could be predictive for one treatment modality compared to another. And I don't know, and I'm open, but I don't know if that accounts for why the secretory IgA is low to begin with. I think one could make the argument with chronic gut inflammation due to poor immune system programming that happened between gestation and their first 3 years of age, that may be a byproduct of their immune system. And it's not that the immune system needs to be fed or revved up, it's that the immune system is chronically reacting to the environment because there was a malformation of the immune system to begin with. So I am open. I think there's some promising.
What do you mean when you say there's been a malformation of the immune system?
So the microbiota and the immune system form in tandem, and they seem to predominantly form by 3 to 4 years of life. So we know, for example, that children that are cesarean birth, formula fed, and have had antibiotics early in life have an increased risk of metabolic disorders later in life and allergic and inflammatory conditions later in life. Because even though this happened at 2 years of age, it manifests at 16 years of age because it sets the tone of the immune system. And so what we may be seeing in a 38-year-old is a byproduct of what happened when they were 4. And so it may not be that the immune system needs to be fed, but it may be that their immune system is chronically hyperreactive, and that's why we're seeing this exhaustion of the immune system, because there's this chronic inflammatory response to the environment. And my approach is trying to figure out what the ideal environmental factors are that work for that host, which looks both at their gut and at their immune system. And I do think there's a few promising interventions. We've been looking more into, and I'm very curious to see how this plays out. So I haven't been using it really in the clinic yet. We're just starting, but there's a compound known as immunolin, which is essentially a bovine serum-derived immunoglobulin.
I think that's one that Dr. Rabar is using.
So I could see the efficacy in that. That seems to not so much, I guess it depends on how you want to define it, but that seems to be a bit more reparative to the lining of the gut, and there have been some clinical trials, right, this important part, showing that especially in recalcitrant IBS-D and in IBD, that this compound, Imulin, available as a prescription and also as an over-the-counter, has the ability to really improve these patients' outcomes. So I could see some, the utility of that in that application, yes.
You mentioned natural prokinetics there a couple of times, and kind of went over it. I just was wondering, is there a standard one you go to? Is there a variable there that you'll switch it up if you didn't get results? Maybe you didn't run the Prokinetic long enough?
So the question is, what prokinetic agents do you like to use?
Right.
So I think iberogast is probably the most well-studied compound, although there has not been one study with any natural prokinetic showing the ability to prevent SIBO recurrence. That's what we are trying to do, because I question how important that will be. And here's my thought process on this. In the one landmark study using tegaserod and low-dose erythromycin that did show the ability to prolong time in remission of SIBO, they both worked, but they didn't work forever. So they just kind of kicked the can down the road a little bit. So is that valuable? Yes. But I also wonder if there are other ways that we can get there. Because remember, this study was a monotherapeutic study. It was, I believe mostly it was antibiotics, I think rifaximin, and then it was Prokinetic. Were probiotics used? No. Was lifestyle used? No. Was a low FODMAP or any kind of diet used? No. So if we know a low FODMAP diet can help to resurrect serotonin cell density, and serotonin cells help to modulate both motility and nociception or pain, then could we be getting to the same endpoint with diet as we are with, in this case, a drug? And would it be essential to use the natural prokinetic? Maybe, but I am using natural prokinetics less and less every day because you don't see any symptomatic improvement from them. I'm not sure, in most cases, some people do see an improvement in constipation, and they're not supposed to be a symptomatic aid, but what I tend to do is, if a patient regresses, we'll oftentimes do a small nudge with the same therapy that got them to that improvement to begin with. So for some patients, if it's a full course of antimicrobials, we'll do a much lower dose, like a quarter of the dose of that antimicrobial in a little bit longer of a term. Or if it was elemental diet, we may have them 3 days a week skip breakfast and just sip on a shake all morning, like a lot of Americans do anyway with the smoothie that they make. So I'm open to the prokinetics, but I think, and again, I am completely open to changing my mind on this, but my suspicion right now is that the utility of motility has been overstated because some of the main thinkers in SIBO are motility specialists. And so there's just this natural biasing of how one views the world through motility. Is it important? Yes. Is some of that research fascinating? Yes. Has the utility of the autoimmunity to the motility apparatus that underlies SIBO been very fruitful? I don't know. I'll be writing more about this in the clinical newsletter. We know that there's no correlation to constipation type IBS. So that's a big shot at the theory right there.
With the existing testing, but like Cyrex has a new SIBO antibody test that apparently IBS-C does is
okay, so will you send me that data? Because I would love, because I want to know the answer to this. But in the studies I've looked at...
By the way, I just interviewed Elroy Vashtani on my podcast this week, and so we discussed this very topic.
Yeah, please send me those papers.
Sure.
I'm very, very curious to look at them. From the studies I've looked at so far, it doesn't seem to be super promising, the utility of knowing that autoimmunity is present. Now, again, there's more here to learn, and have I done an exhaustive review on this yet? No. But as I've been digging into it, right, you start kind of getting the initial sense, and my initial sense tells me that the importance of treating motility with these prokinetic agents may not be as helpful as we think it is. Again, totally willing to change my mind on that when the data becomes available, but for right now, I'm finding probiotics and low FODMAP diets and potentially antimicrobials and even low-dose antimicrobials, elemental diets, getting people to be less afraid of food and having them expand their diets. All these things have been more effective, in my opinion, than prokinetics. Just as one quick example, I had a patient last week. She has gastroparesis and she has SIBO, or she had SIBO, and she got better with her other doctor, but kind of hit a plateau. She came into my office, and one of the things she asked me was, "Will I ever be able to eat fruit again?" And I said, "Well, it's fairly probable that you'll be able to eat fruit again. Most patients can expand their diet with time. Why aren't you eating fruit?" "Well, I read it was bad for SIBO." "Do you have a reaction to fruit?" "No, I feel great when I eat it." Then yes, you can eat fruit tomorrow.
What about the patients who react to everything and are down to
right? Well, that's another story.
Yeah.
But the point I'm trying to make is some patients make themselves sick with fear of food, but they haven't qualified that they should be afraid. And I see nutritionists here shaking their, I'm assuming people who work a lot with diet, because you do see that. Now there are some patients who are very reactive. You have to treat their gut, you have to heal their gut, and then they'll be able to eat more. But this poor gal had better energy and better bowels when she ate fruit. She felt better, and she was avoiding it because she read it was bad for SIBO, which she really no longer even had. Her retest was normal, but she was so afraid to eat fruit because the fructose can feed SIBO that she was literally making herself more fatigued and more constipated, not eating a food because she thought she should avoid it. So in some cases, it's not even SIBO. And so I think we have to be very discerning and calculated with what we say. Right? We should be throwing around, "Oh, my SIBO is flaring because I'm bloated." No, you're bloated. "My adrenals are off because I'm tired." No, you're just tired. Like, stop making every symptom that you feel into a condition. And I do a lot of what I do in the clinic is try to unwind this programming with patients, and it's damaging. It is hurting people. One thing I think is very important: if you can't get it perfect, you can only shoot over or shoot under in terms of how ill you make a patient think they are. Always undershoot instead of overshoot. And this ties into thyroid. I see so much fear around thyroid that is not helping patients. "You have Hashimoto's." All right, take vitamin D, take CoQ10, take magnesium, reduce or avoid gluten, heal your gut. All right, I'm not going to scare the bejesus out of you. But I think we're in trying to help people, sometimes we don't think enough about the impact of what we say has on patients. So really, if you can't get it perfect, you're better off to undershoot and imbue in them a feeling of them being healthier than they are, because your self-perception of your health does manifest measurably in your health. And the counter-argument against that is often, but they have to be motivated to change. Listen, you fearing them is not going to change their perspective on life. When they are ready, they will seek it out, right? When the student is ready, the teacher will reveal himself. When they are ready, they will do it. So fearing people, and Hashimoto's in my mind, and unfortunately SIBO is getting close to this, are two of the worst ones. There was recently a study published in Tehran that followed patients with Hashimoto's antibodies for 9 years. How many of those patients do you think developed hypothyroid? Percentage? 3 guesses. 5%. Good. 5%. See, that is a good answer. I like you. I think most patients are under the belief, and tell me if you agree or disagree, I'm very curious to get other people's opinion on this, that they have 80, 90% chance of becoming hypothyroid if they have Hashimoto's. Am I the only one who's seeing that kind of feeling in patients? Yeah? So they found...
But if your body is attacking your thyroid gland, that's still something that functional medicine practitioners should be concerned about.
Yes, but we don't want to tell people that the situation is worse than it is. In this study in Tehran, about 10% of patients, maybe as high, I think, as 16 in one arm of the follow-up, actually became hypothyroid. So when the patients come in and they have been reading thyroid stuff and they tell me that they have Hashimoto's, it seems to carry this weight of, I am almost for sure going to become hypothyroid. This is one of the worst things that's ever happened to me. So these things are important, but we have to strike the appropriate balance of how much weight we put behind these things, because if we make patients fearful, we're really not helping them. And thyroid, I think, is, and this is, I think, a contentious issue, but I looked at thyroid antibodies. If I can get them between 100 and 300, I look at that as a clinical win. Now, the data here are not incontrovertible, but I think you see a trend that the low hundreds really presents minimal risk. Now, there's a context we should encapsulate this in. If someone has done interventions to improve their thyroid, and their thyroid antibodies have come down, and they're nestling between 100 and 300, I'm happy with that, right? If someone's done nothing and they're between 100 and 300, okay, let's try a little bit more to drive those down. But that context is really important, and this is one of the case studies that I won't go through, but essentially, this gal, June, you can read her write-up on our website. She came in and she had elevated thyroid antibodies. I believe she had fatigue, depression, constipation, and insomnia. Her antibodies never changed, but she was able to cut her dose by a third. All of her symptoms went away, and she felt fantastic, right? She also still had elevated H. pylori and Epstein-Barr antibodies that did not respond to treatment, but she became a lot healthier. And that was the most annoying case study to write up, because we did many visits because she was really motivated to nip all this in the bud. She was one of the first cases that really taught me you can have someone with a positive lab finding who is absolutely asymptomatic and healthy. So yes, we can use the antibodies as something to guide our intervention, but I would be very careful with how stark of a prognosis you paint for the patient as you're embarking on that journey.
When you're doing testing, like this example you showed here, you have a histamine machine.
Mm-hmm.
Now, in what instances, or how many instances have you found that maybe it was maybe a heavy metals issue, like lead, mercury,
Sure.
aluminum,
Sure.
type of thing, and where do you come in there with testing for that?
So essentially the question is, how can environmental factors like heavy metals impact histamine? And they definitely can. And that's another important thing to look for, environmental provocators of the immune system as a driver of histamine. I had one patient, it's kind of a funny story. Her reflux and gastritis type symptoms had completely cleared. And then all of a sudden they came back. And it didn't fit any other pattern I've seen before. Luckily, she told me that they just bought gerbils for her son. She was allergic to the gerbils. And guys, I'm not giving you one of these, sometimes I feel like we embellish our case studies. I was very diligent in my analysis. It was the gerbils. And it was a little bit of a tough thing with the child to get rid of them, but reflux went away after she got rid of the gerbils. So gerbils, something to consider. But also if there's mold in the environment, that's something to think about. And heavy metals, I did a fairly comprehensive review of the literature on heavy metals, and the vast majority of people who have exposure to heavy metal in a normal environmental context show no mortality or morbidity. There's a small subset who do, but I think the utility of heavy metal detox has been grossly overstated. And at some point I'm going to release all that information. It's just I can only do so much at once. One of the studies, I believe, was a Swedish study that followed tens of hundreds of people, and they tried to correlate amount of mercury fillings to any measurable symptomatic or disease parameter. The association, 0. There's also a study that detoxed one half of people with a mercury detox and the other half were given placebo. They both improved symptomatically. What does that tell you? There's a placebo effect. I think there's a small subset of people, and some of the research points that people who have an allergy to mercury, which you can test with an ELISA test, they may be the ones that really benefit. So I'm open to it, but I would really love to find someone who specializes in this, but they're really discerning. Because one of the challenges that I have is sometimes I find people who are experts in their field, but they just seem to be drinking their own Kool-Aid. And I really struggle with that because I want to find someone who is a specialist in metal detox, and they just flatline it for me and say, listen, 60% of the people who think they have a problem with metals don't. And we don't do it. I'd love to see that because that's what it would be more in alignment with what the data says. So I do think there's a smaller subset that could trigger histamine, definitely. I would recommend leaving an environmental intervention to end phase after you've modulated their gut, because some of these things like mercury or mold, they're harder to identify. And if they're more difficult to identify, you have a lower probability of success of that therapy. And so I'm trying to minimize that as much as I can in my office, right? The amount of times you have a patient do something and nothing happens, we want that to be as close to 0 as possible because it's not a good feeling. So for me, I don't do that therapy. I've occasionally referred for it. And I think Brian Walsh, if you guys haven't listened to Brian Walsh's appearance on our podcast about detox, he blew my mind. It was awesome. And so I think he's probably got one of the better models of an evidence-based detox approach.
Talk to Christopher Shade. He's really good with heavy metal detox.
I was always under the impression that you can't feel the gut until metals are removed as well. What's your...
I've been in practice now for 8 years, and it's rare I ever have to refer a patient out. And so I would think that I'd be floundering more. And it is possible I could be missing this, right? Because the patients who don't do well tend not to come back. But I do have a policy I've been trying to implement, and I'm more diligent in implementing this, which is in patients who haven't responded, we follow up with them every 6 months and we ask, did you find something that helped you? Now sometimes we refer them and then we'll follow up and say, did that referral pan out? Because I want to know, right? I want to know where my holes are and where my gaps are, but I would estimate that would be the vast minority of people who have an actual problem with metals. And for example, if that theory was true, people who had 12 or more fillings in their mouth in that Swedish study would have likely seen an association to IBS, even if that association was only 2%, right? But there was no association found to IBS in that population-wide analysis with people who had progressively more fillings. So again, I'm open to it, but I think if you get your gut healthy, you actually can help to facilitate detoxification. Part of that's just my conjecture. But I think that may be a more fundamental pillar that could supersede the importance of a direct detox therapy.
I'm
I'm sorry, you're talking about the Swedish study and mercury in the mouth. And a couple things you said, I just want to challenge a little bit.
Please.
Our 3-year-old children, or 4-year-olds, have had 36 to 49 vaccines by that age, and they are heavy in metals. They're incredibly heavy in
No, you when you say R, you mean U.S. compared to
in the
Sweden?
U.S.
Okay.
And they have much less over there. We have 1 in 22 boys in the United States with autism, 1 in every 34 children. But going off of that, the mercury is almost the cash cow against people finding out really what the aluminum is doing. When you have the aluminum is a powder content, and if you keep, let's say, re-injuring your knee, the white blood cells of the aluminum are going to go to the knee. We've had football forever, but all of a sudden we have tons and tons of young men with CTE, where their brains are being eaten away, where they have the highest aluminum content in the world, because when their head gets injured, the white blood cells and the aluminum go right to the brain. It's way higher than people in Alzheimer's. Any study that talks about just taking mercury out of the mouth has an agenda. They have to, because we give these kids like 5,000 micrograms. You're not supposed to get more than 25. Tiny little babies, and they're shooting them when the mothers are pregnant, and we're seeing a huge 4,000% increase in death. So when you say some Swedish study showing that taking out mercury from the mouth is so besides the point of what's really going on, it's not
Sure.
even like.
Well, so essentially, I think the point is, to just kind of try to encapsulate it for the audio here, is that the mercury and other metals contained in vaccinations isn't accounted for in my posit, and it's not. Now, I don't profess to be an expert here, but I'm sneakily suspicious that it may more so be the adjuvants and the immune stimulation that has the detriment. And I think you can make much more of a case that if you overstimulate the immune system, you can stimulate it into a skewed immunity forever. And this may be why some of this research has shown that by delaying the schedule of the vaccination, you can actually decrease some of the morbidities that are associated with that. But again, I don't profess to have done a comprehensive review on the issue there. I remain open. Now, I used environmental and dental mercury as a proxy, right? And I can speak to that and say that there has been no association outside of a small minority with those forms of exposure. The vaccines is another issue, and I would love to talk about it, but I think it's taking us a little bit off topic. I think that the truth on vaccines lies somewhere in the middle between conventional medicine and alternative medicine. All right. Well, I'd be careful because if you're not open, then you can never learn. And I think it's somewhere in the middle where they're not quite as bad as they're portrayed to be, but there's definitely some documented damage. And there's some questions there that I have. And I've been collecting studies on this as I come across them for a while now. Clearly, they can cause damage. And I also think that there are populations for which they pose the potential highest risk. For those with a family history of inflammatory and autoimmune conditions, I think we need to be the most discerning. But I'm not a vaccine alarmist, but I remain open. And I can't profess to have familiarized myself with all the nuance of that body of literature. But it's a good question, and I'm always happy to be challenged.
What's your opinion on the recent popular use of the carnivore diet to help with gut issues and inflammation?
Yeah, so the question is about the carnivore diet.
This is eating meat only.
Yeah, meat only.
So much Jurassic Park.
There are numerous compounds in plants that can be noxious to the gut. And I see the utility in a carnivorous diet, but I see it more so as a temporary approach to help reduce insult, but not as a solution. So we know that FODMAPs can irritate the gut, mostly in plants. We know that saponins can irritate the gut. Lectins can irritate the gut. Too much fiber can irritate the gut. Too much sulfur can irritate the gut. Sulfur not exclusive to plants, but there are some very high sulfur vegetables. So there are many plant foods that can be noxious. So it's not surprising to me that people may do kind of a cleanse with a carnivore diet. But the anthropological data really does not show any society consuming or subsisting on a carnivorous diet. Yes, we do see that maybe 50 to 60% of the calories, roughly speaking, from worldwide observations of hunter-gatherer populations did come from animals, but that's not 100%. So I would say that if someone has to do the carnivorous diet to feel well, then there's a fairly high probability that there's some kind of sensitivity to plant compounds, and by healing the gut, you can most likely ameliorate that. Also, by helping them identify where their sensitivity niche is on the whole canvas of plant foods could help them not overconsume. Some people just reduce dietary histamine and they feel a lot better, and some of those are plant-based foods. Other people just restrict dietary sulfur and they feel a lot better. A small niche of people reduce dietary oxalates and they feel a lot better. Now, would one way of getting there be to avoid all of those? Yes, but that's like saying one kid on the playground bullies you, so you just never go to school, right? It's not a good, avoid all social interaction because one person's a problem. It'll work, but there may be some unintended side effects and consequences to that.
Can you speak about visceral hypersensitivity, which may be something that occurs in some of these patients who are seemingly reactive to almost every food?
Sure. So what's interesting here is some of the research in low FODMAPs show an improvement in IBS symptoms without a significant change from normal gas pressure to abnormally low gas pressure. But even a subtle downward amount of gas may allow no more triggering of the visceral hypersensitivity. So what some of the researchers are theorizing is that some people with IBS may be hypersensitive to gas pressure. So you have this kind of normal range, and people with IBS may need to get down to the lower end of the normal range in order to not any longer, or to no longer be hypersensitive. Some of that is also probably mediated by the immune system, which there's a multifold ways of intervening there that we've already discussed. And then some of it may be due to serotonin, but we also know that a low FODMAP diet can help with serotonin. And I don't want to make the case that the low FODMAP diet is like this miracle diet. It's just, I think, important to provide that as juxtaposition against all the contradictory information saying that you have to feed your gut bugs in order to get healthy, which really disserves some people. And I think immunolin, the other immunoglobulin, may be helpful with that. Probiotics can also be helpful with hypersensitivity. So yeah, it's definitely one of the mechanisms that underlie IBS. And if you go through the kind of suite of interventions that we've discussed tonight, then you should be able to help with that in the majority of cases.
I want to address the gut motility issue. I had really good experience by just looking at that. So at last year's IFN conference, Dr. Karazian did a lecture on vagus nerve, and he discussed its effect on SIBO and on digestive enzyme production, and he gave some measures on how to increase vagal nerve tone. So I discussed this with a physical therapist that I've been referring to for a long time that does visceral work. And I spoke to him about, is there anything that he could do to do vagal nerve stimulation? And so I've been sending patients to him for the last year, and I've had really good success. So he'll do something, sometimes there's scar tissue around the vagus nerve, or he does some things to, stimulate it.
Is there a mic nearby here? Because this is going to be too long for me to repeat. Where's that mic that was floating around? No, it's fine. I just feel... So how about going forward, guys? Just wait till the mic gets to you, just so that people listening to the recording. Because what you're saying is good. I want people to capture that. But just continue from where you were, please.
It's worked really well. So should I repeat?
No, I just go ahead. Sorry.
No, where I left off.
So essentially, you've been referring to people to a physical therapist who can help with kind of the gut-brain connection, vagal nerve stimulation.
Close to the mouth. Not better? So for the past little over a year now, I've been sending patients. So, you know, I send people to Cedars for hydrodurate testing. You know, that's what I've been doing. What I found was I started to see such good success with this vagal nerve work that I started having patients see him first for 2 or 3 visits and see what I'm left with, basically.
Right.
And I've just seen enormous improvement. In some patients, I don't have to send them at all, or I don't have to, you know, use, you know, whatever treatment, you know, antibiotics or herbal therapy or that kind of thing. I don't know, it's worked really well.
By the way, Dr. Karazian recommends forceful gargling,
Correct.
gag
And I started
reflex,
out with
coffee
that.
enemas as ways to stimulate the vagal.
Correct, and I started out with all that, you know, I had that protocol, and I had patients start to do that, and, you know, and it had a little bit of success, and then I thought, well, let me see what he can do, you know?
And so is he?
And he's done a lot of research, and he did a lot of research on it too.
So is he doing? Is there a predominant aspect of his therapy? Is it manual scar tissue breakdown?
Correct.
Okay,
yes.
so that
He
gets
tried
into
to get
something.
also the valves working better.
So I think there's something there, and I don't know that it's motility specific, but I'm open, and I'd actually like you to give me that person's information because we're going to be doing a 3-part podcast series on this. Hold that for just 1 second. There's worm therapy.
I have one other thing I wanted to say, just tell you really quick. Karazian spoke about the ileocecal valve that it can cause translocation of organisms. So he works on that valve.
Okay. So I do think there's something to visceral therapy for the gut. And who I think has done a good job of documenting this are Sarah and Belinda Wern, who are over at Clear Passage. They've published a number of trials showing benefit with various conditions. And so for some of these recalcitrant cases, especially if there's a history of abdominal trauma or some kind of really bad endometriosis or fallopian tube obstruction,
Or previous surgery.
yeah, or previous, obviously previous surgery or impact trauma, and especially if they say they have regional pain when they ovulate, so, you know, anything like this that gives you an indication, also part of our initial paperwork, then we keep that in the back of our minds to potentially make a referral for this therapy. So I do think there's something to visceral therapy. I don't know that it's, and I am open, but I've found that the promises of stimulating the vagal nerve have more often fallen short than they've delivered. I also may be seeing a skewed perspective because for the people who it works, they're not going to come to my office. But I have seen a number of cases, just like you said, who are doing some of these stimulation therapies for the vagal nerve and not really getting much better. It's funny that you say this person is doing manual therapy. Right. I do think there is something to that, but it may not be the vagus nerve. It may just be adhesions in the peritoneum and the abdominal wall that needs to be rectified. So I do think there's something to that, but please make it a point to give me that or your information afterwards.
I know some chiropractors using cold laser, and they claim that stimulates the vagal nerve as well. My friend Dr. Rob Silverman said that he's using it a lot.
Okay, cool. Wait, Mike, let's get you the mic.
I'm Italian, I can talk really loud. Can I wait for the mic? Sure. But we still need to repeat the question.
Can the mic person sit in the center here, just so that may make it a little...
We still need to repeat it for the recording.
Oh, we do. Oh, okay, so I forget it.
I was just wondering at what point, because the gut, and this I guess kind of segues into thyroid as well, at what point do you start looking at liver intervention and liver protocols? Because I think sometimes, and I'm sure you get a lot of advanced clients who have done their research, maybe they've been on a gut protocol, and because they share a lot of the same pathways, at what point do you start saying, like, maybe we should dig into, addressing the liver?
So essentially the question is, when do you incorporate liver therapies into the overall treatment? And it's not often that we actually have to do anything for the liver, and it's probably because of the profound impact of hepatic circulation via the portal vein or portal circulation to the liver. And this may be why, for example, probiotic clinical trials have shown the ability to reduce liver enzymes and help with non-alcoholic fatty liver disease. So there's a profound connection there. There are some cases where high-dose bile has been helpful. But direct liver therapy, not very often, unfortunately. There's one other thing that this bumps into, which is people who have had their gallbladder removed and how do you handle that. And one case study in our clinical newsletter documented a patient whose only problem was that she needed to stop taking bile. Now, it's important to understand this. Some people who've had their gallbladder out will do better from bile, yes. But there's also a subset of patients post-cholecystectomy who will report diarrhea. It's known as bile acid malabsorption. Now, what happens when the gallbladder is gone is there's just a steady flow into the intestinal tract. That may overwhelm the absorptive ability to reabsorb, because bile goes all the way down the intestinal tract, and at the terminal ileum, it's reabsorbed. If it's not reabsorbed and it makes its way into the colon, it functions as a laxative. So in some people, they actually can get over their diarrhea by stopping the supplementation with bile or by using a bile binding agent. So again, it can manifest anyway. Some people who've had their gallbladders out will do better with supplemental bile, but some will actually need to be pushed in the other direction.
And bile is also one of the natural mechanisms by which the body prevents small bacterial overgrowth from occurring.
Right, exactly. Yeah. Other questions?
Any pearls for Crohn's?
Any pearls for Crohn's? And after that, I'm going to go on a little gut thyroid rant, because the gentleman asked before and we didn't get back to that. I wouldn't say pearls. A lot of the same stuff we do for IBS, we do for IBD. But actually maybe one pearl, and that would be elemental diets. For recalcitrant and non-responsive inflammatory bowel disease as a general category, but more beneficial actually for Crohn's. This is kind of funny, or ironic, I guess. Probiotics work better for Crohn's, not as well, better for ulcerative colitis, not as well for Crohn's. Elemental diets work better for Crohn's, not as well for ulcerative colitis. So you can use that knowledge to guide your therapeutic recommendations. And as I've read, I don't live in Europe, so I can't say firsthand, that one of the frontline therapies for inflammatory bowel disease is an elemental diet. And you hear horror stories that elemental diets are terrible tasting. It's not true. We have released a formula known as Elemental Heal, which is a semi-elemental formula, and it's very palatable. Also, the Physician's Elemental is also very palatable. So there's a newer generation of elemental formulas that are quite palatable, and again, another thing that you have to decondition patients regarding, because they'll go on the internet and invariably they will conclude that, oh my God, this is going to be awful, they taste so bad, it's going to be so hard. And I can't tell you the amount of patients who have said, wow, it wasn't nearly as bad as I thought it was. And then regarding gut thyroid, just I guess a couple things kind of to wrap us up. One study looked at 1,809 patients trying to find what the highest association to hypothyroidism, to SIBO was. And they found that the highest association to SIBO was being hypothyroid or being on levothyroxine. So there's definitely an association. That doesn't mean stop taking levothyroxine if someone is on it, but it means there's some kind of underlying commonality between the two. Another study in Poland recently found that those with SIBO had significantly higher levels of thyroid antibodies. The effect size was small, but it was significant. Another study has also found that those with SIBO have an increased incidence of H. pylori, and H. pylori has been correlated with thyroid autoimmunity in a number of trials, and one interventional study in H. pylori found the treatment of H. pylori could lower thyroid antibodies. Maybe the least appreciated facet of this is that you can allow patients to need literally half of the dose, in some cases, of their thyroid hormone if you optimize their gut health, because they're malabsorbing their hormone, right? We wrote up a case study for a gal named Laura, also in our newsletter, also on our website. She lost weight, gained energy, had less joint pain, and was able to go on half the dose of levothyroxine. And this wasn't me trying to push that. It was her endocrinologist who's monitoring her, and he goes, boy, we need to cut your dose down because all of a sudden your blood levels of thyroid hormone are going too high. Why? You're now more consistently and more efficaciously absorbing your thyroid hormone. So in some cases where the dose of the thyroid hormone can't become consistent. The key is the gut. And you see this in some of the medical literature for people with chronic ulcers. They give them liquid gel tab form thyroid hormone known as tyrosine, and their unstable TSH and non-responsive symptoms normalize because it's easier to absorb. Now, we can achieve that same thing, theoretically. It hasn't been published yet, but I've seen a number of cases of it by just improving their gut health.
Attention, please. The library will be closing in.
All right, well, I guess that's it.
The second floor restrooms will be closing in 15 minutes. If you need a library card, please go to the customer services desk immediately. Thank you.
All right, well, I guess we'll
Okay,
wrap it up.
so
I missed the last.
The last thing I said
We
is
could do the same thing
we can get that same impact, at least theoretically, it hasn't been published yet, by optimizing one's gut health. And I've seen this enough times where it's not a theory. There have been enough patients, and in some cases I explain to them that you may need to have your thyroid dose decrease if you start feeling irritable and anxious and your heart's racing. You may be so much more efficient at absorbing your dose now that you're looking like you're overdosed. And patients love that. They love going on less medication, even though their blood levels are staying the same. They're taking less, and they feel good about that.
So thank you, everybody. Just to wrap this up, I just wanted to recommend that you consider signing up for Dr. Ruscio's clinical review newsletter on his website, drruscio.com. Check out Dr. Ruscio Radio, his podcast, and pick up Healthy Gut, Healthy You, his new book. So thank you, and we'll see you next month.
Thank you, guys.